Regarding the anticoagulation regimen in nephrotic syndrome, as per the latest Kdigo 2021 guidelines. So in the guidelines, they have mentioned full anticoagulation have to be considered for up to 3 to 6 months or throughout the course of the nephrotic syndrome treatment if the patient is having any risk of this episode, thromboembolic events. And prophylactic anticoagulation should be employed in patients with nephrotic syndrome and the risk of like thromboembolism risk exceeds the risk of bleeding. Few points regarding the thromboembolic events in nephrotic syndrome. It is more common in adults than in children, but reports have been shown in children also events of this thromboembolism, and it is more common in the venous system than in the arterial system. But in the arterial system, almost all the arteries have been reported. In the cardiac, pulmonary, CNS, even the retinal vessel arterial thrombosis have also been reported. So whenever a nephrotic syndrome patient presented with any features of CNS manifestation or any other systemic manifestation, always consider possibility of thrombosis whenever there is a high risk of thromboembolism in the form of serum albumin less than 2.5. Among the venous system, deep venous thrombosis and renal vein thrombosis are most common and is more common with the membranous nephropathy. Patient will be having typical sudden onset flank pain along with massive hematuria or proteinuria will be there. So these points have to be kept in mind, and these thromboembolic events are more common with the membranous nephropathy than with other nephrotic syndrome, even though it is reported in any nephrotic syndrome with low albumin. Among the anticoagulants, as of now, heparin and warfarin are the agents of choice. There are no RCT available to compare these two drugs. Directly acting on oral anticoagulants are not yet studied in context of nephrotic syndrome. So coming to the summary table which is available. So anticoagulation for 6 to 12 months whenever the patient had any event of venous thrombosis, arterial thrombosis or pulmonary embolism or non-valvular atrial fibrillation also. This is an indication for starting anticoagulation. When to consider for prophylactic, when the patient doesn't have any episodes of thromboembolic event, still we have to give anticoagulation in the situation when the serum albumin is less than 2.5 along with any of the following: increased risk of thrombosis when the proteinuria is more than 10 gram, patient is obese, genetic predisposition, heart failure as per the NIA Association class 3 and 4, any history of recent surgery or prolonged immobilization. These are all the risk factors where we have to consider for prophylactic anticoagulation if the serum albumin is less than 2.5. What are the absolute contraindication for anticoagulation? As we know, whenever there is a high risk of bleeding, even frailty, GI bleed, any CNS risk of bleeding, then we have to avoid. Coming to the drugs, low dose anticoagulation, either unpatched or heparin 5000 unit can be given twice a day. And regarding the low molecular weight heparin, dose reduction have to be considered as per the patient GFR. And regarding the warfarin, bridging therapy have to be done with heparin. In heparin, higher dose might be required since antithrombin 3 is lost in the urine. And the target INR is 2 to 3. And there are no clear-cut randomized trials so far to support any of these things, but these are all the recommendation. And whenever the patient is on warfarin, always look for the drug interactions. With respect to the factor 10A inhibitors, so the dosing is according to the serum creatinine, and the urinary clearance of these 10A inhibitors have been shown here: apixaban, edoxaban, and rivaroxaban. The pharmacokinetic mechanisms in these nephrotic syndrome have been not yet clearly studied, and here are the data for the protein binding with respect to the factor 10A inhibitor. Apixaban having maximum with up to apixaban and rivaroxaban almost having 90% of protein binding. So these drugs need further study in this situation. And with respect to the DTI, there is a direct thrombin inhibitor. This is also not systematically studied in patient with nephrotic syndrome, and it also have to be adjusted as per the creatinine clearance. Argatopan, dabigatran clearance is given over here. Similar to the factor Xa inhibitors, this also not yet clearly studied regarding the pharmacokinetic and dynamic mechanism. Protein binding is up to 50% in argatopan and 35% in dabigatran. So this is another flowchart. Basically, this flowchart was given for membranous nephropathy management. But in this Kdigo, any other nephrotic syndrome, this chart can also be employed. Whenever serum albumin is 2.5 and there is a high risk of thromboembolism versus the bleeding risk, there is a separate tool which is called the GN tool, where we have to put the patient basic detail, which include age, sex, creatinine, urea, proteinuria, those things that will give you the risk of bleeding and risk of thrombosis. If there is a high risk of bleeding, no need for warfarin, patient can be considered an antiplatelet like aspirin. Whenever there is a low bleeding risk, we have to consider warfarin after the bridging therapy with heparin. So when serum albumin is less than 3.2, again the risk of arterial thromboembolism have to be taken based on the Flemington score, GFR, diabetes, and previous thromboembolism event. If there is additional risk, as per the risk calculation, if it is high, anti-hypercoagulability things in the form of antiplatelet aspirin can be given. If the serum albumin is more than 3.2, there is no need for any anticoagulant as per this flowchart. What is this GN tool? This is the online tool which is available. This is basically for membranous nephropathy, where this have age, sex, race, creatinine, albumin, burn, hemoglobin, history of hemorrhage, hypertension, and dialysis. And what is the risk ratio considered acceptable as per the patient risk? So this will give the estimate of risk of bleeding and the thrombosis as per this one GN tool which is available online. The anticoagulation can be decided as per patient to patient basis.